The following podcast is part of a certified educational activity titled Advances in the Management of Allergic and Inflammatory Diseases, Highlights from Washington, D.C. and San Francisco. Access the entire activity and complete the post-test at peerview.com/NCE860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Paul Yamauchi from the David Geffen School of Medicine at UCLA. Welcome to this educational activity focused on updates in allergic and inflammatory diseases that were presented at the American Academy of Allergy, Asthma, and Immunology, or Quad AI, in San Francisco, as well as the American Academy of Dermatology, or AAD, the annual meeting in Washington, D.C. Specifically, I'll be exploring data about treatments for atopic dermatitis that were presented at both meetings. Joining me in this discussion is Dr. Jonathan Koren from the Ronald Reagan UCLA Medical Center in Los Angeles, who will discuss new data related to asthma, chronic rhinosinusitis with nasal polyposis, and eosinophilic esophagitis that were presented at Quad AI. Systemic inflammation encompassing T helper 2 or Th2 type responses has emerged as a unifying feature of diseases including atopic dermatitis, asthma, chronic rhinosinusitis with nasal polyps, and eosinophilic esophagitis. For many children, the onset of atopic dermatitis marks the beginning of a progression from atopic dermatitis to food allergy, allergic rhinitis, and eventually asthma, a scenario frequently described as the atopic march. So let's talk about atopic dermatitis. Moderate to severe atopic dermatitis significantly affects the quality of life of patients due to itch, lack of sleep, embarrassment, social isolation, and effects on mental health. As a result, we must be able to effectively treat this disease. The management of atopic dermatitis is evolving, particularly with the availability of a biologically targeted therapy, as well as a variety of novel therapies under development, including topical and new oral agents. Let's discuss the new data for these treatments that were presented at AAD and Quad AI, but let's first look at the study that examined the economic burden associated with atopic dermatitis. Because of the significant disability and treatment burden that can be associated with atopic dermatitis, healthcare resource utilization and costs can be quite substantial. In addition, the first-line therapy for atopic dermatitis is topical steroids as well as topical calcium inhibitors to provide adequate control of atopic dermatitis. This study looked at results of a real-world retrospective database study that assessed whether time to therapy escalation among uncontrolled patients with atopic dermatitis impacted healthcare resource utilization and costs that were presented at the AAD. This study included 368 patients with atopic dermatitis, and the median time to treatment escalation was 210 days. Patients with shorter time to treatment escalation had fewer outpatient visits per month compared to patients with longer time to escalation. In addition, healthcare costs were lower for patients with shorter time to escalation than patients with longer time to escalation. Let's now talk about a prospective observational study called EUROSTAD. EUROSTAD stands for the European Prospective Observational Study in patients eligible for systemic immunosuppressive therapy for atopic dermatitis. This is an observational research study that aims to describe characteristics of patients with atopic dermatitis treated with systemic therapy over time and their management in a real-world setting. 308 patients with atopic dermatitis aged 18 years and above will be followed for 5 years. At enrollment, 92% were receiving systemic immunosuppressive therapy, and this included cyclosporin, methotrexate, corticosteroids, azathioprine, mycophenolate, and Dupilumab. In this study, patients also could use concomitant emollients, topical corticosteroids, and topical calcium inhibitors, which reflects real-world experience. In addition, most patients had at least one atopic comorbidity, including allergic rhinitis, asthma, food allergy, and allergic conjunctivitis. And most patients had moderate or severe atopic dermatitis at baseline, either an IgA score of 3 or 4. Despite the widespread systemic therapy use, the majority of patients have significant disease burden and impacted quality of life. However, what you need to take into account is the fact that once patients started therapy, that their quality of life had improved, which this study did not take into account yet. Let's now focus on the first biologic agent approved for atopic dermatitis, which is Dupilumab. Dupilumab is a fully human monoclonal antibody that targets the IL-4 receptor alpha subunit and inhibits the binding of IL-4 and IL-13 to the respective receptors. Dupilumab was the first biologic agent approved by the FDA for the treatment of adult patients 18 years and above who have failed topical therapy. And just recently, Dupilumab was approved for adolescent patients 12 to 17 years of age who have moderate to severe atopic dermatitis. Dupilumab is also approved in other countries, including Europe and Japan. And we'll talk about some studies called SOLO-1 and SOLO-2, where Dupilumab was used as monotherapy to treat the signs and symptoms of moderate to severe atopic dermatitis. And at the AAD, a post-hoc analysis of these studies were presented. And the objective of this study was to determine the proportion of patients with moderate to severe atopic dermatitis who attained clinically meaningful responses in one or more of the three major response domains, which included signs, symptoms, and quality of life. Patients in this study on Dupilumab were treated either every week or every 2 weeks, and the results were compared against placebo. What the study showed was whether you were on every week dosing or every 2-week dosing, the outcome was about 50% of patients on Dupilumab attained those endpoints versus 30% on placebo, and this was considered statistically significant. And this was early as week 1. But at week 16, there was more improvement, so that roughly up to 3/4 of the patients on Dupilumab attained the endpoints versus 35% on placebo. So results of this study shows that being on Dupilumab substantially improves the quality of the patient's life, as well as improving the itch and the outcomes of the rash of atopic dermatitis compared to placebo. The adverse events that were seen more commonly with Dupilumab were injection site reactions and conjunctivitis. The next study we'll talk about is an off-label use of Dupilumab in pediatric patients with atopic dermatitis, and this was a multicenter retrospective review. In this study, 109 pediatric patients with a mean age of 13.1 years and 41% were females received Dupilumab for atopic dermatitis, and this study was evaluated over a course of 21 months. 82% received a loading dose, in which the mean dose was 8.5 mg per kilogram. Also, 75% received the adult dose, which was 600 milligrams. 74% received a 300 milligram adult maintenance dose. After receiving a mean of 16.5 doses over an average treatment period of 9 months, most of the 109 patients saw improvement in the Modified Investigators Global Assessment Scale, which is a 5-point scale. 70% had an improvement of at least 2 points. 22.5% showed a 1-point improvement. The adverse events in this study included facial eruption, injection site reaction, upper respiratory infection, and conjunctivitis. So this study supports the use of Dupilumab in the pediatric population with moderate to severe atopic dermatitis. Next, we'll look at the pivotal phase 3 study that was done to look at the efficacy of Dupilumab for adolescents 12 to 17 years of age, and this was a randomized double-blinded trial. Patients were randomized to receive Dupilumab for a course of 16 weeks, either at 200 milligrams if the baseline weight was less than 60 kilograms, or the standard dose of 300 milligrams if the baseline weight was more than 60 kilograms. And they received Dupilumab every 2 weeks, 300 milligrams of Dupilumab every 4 weeks, or placebo every 2 weeks. In this study, Dupilumab had an acceptable safety profile similar to that observed in the adult atopic dermatitis population. So in this graph, what the data shows that regardless of which dose was used, whether it was Q2 week or Q4 week, both groups showed a statistical significant improvement over placebo for the IgE of clear almost clear or the EASI-75 response at week 16. Next, let's talk about JAK inhibitors. There are several in investigation, either as an oral agent or a topical agent. Let's first talk about Ruxolitinib. Ruxolitinib is a potent selective inhibitor of JAK1 and JAK2, and it's under investigation for use in atopic dermatitis. And there were a few studies presented at the AAD and Quad AI on Ruxolitinib. Results from a phase 2 study were presented at the AAD on the effects of Ruxolitinib cream on itching and quality of life in adult patients with atopic dermatitis. And what the study showed was a substantial reduction in the itch score that was observed within 36 hours after the first application of 1.5% Ruxolitinib cream twice daily versus vehicle. It was also compared against the topical steroid, which is triamcinolone 0.1%. Overall, a reduction in itch was positively associated with a decreased quality of life burden. So this graph looks at the different concentrations of Ruxolitinib that was used compared to placebo and triamcinolone cream. You can see that there's a dose-dependent response with Ruxolitinib cream at the 1.5% either once a day or twice a day. In addition, you can see that the efficacy of triamcinolone was in between the placebo group and the higher concentration of Ruxolitinib. So in that regards, this cream might fulfill an unmet need of a better non-steroidal agent to treat atopic dermatitis. In addition, the effects of Ruxolitinib looking at Th2 inflammation in adult patients with atopic dermatitis was also analyzed. This study was presented at Quad AI, which examined the effects of Ruxolitinib cream on Th2 biomarkers and the relationship with clinical measures. The application of Ruxolitinib cream 1.5% twice per day for 8 weeks resulted in a significantly reduced thymus and activation regulated chemokine known as TARC CCL17 compared with vehicle-treated patients. In addition, the total serum IgE levels were also reduced in patients treated with 1.5% Ruxolitinib cream, either once a day or twice a day. However, levels of TARC CCL17 and IgE at baseline did not predict Ruxolitinib cream treatment response. So the results suggested an ability for Ruxolitinib to modulate disease course through inhibition of select Th2 biomarkers. Let's talk about an oral JAK inhibitor called Upadacitinib. This is a selective JAK1 inhibitor which is under investigation for the treatment of atopic dermatitis, and will discuss the results of a 16-week phase 2 study in adults with atopic dermatitis evaluating the effect of Upadacitinib on the absolute eosinophil count and serum IgE levels. And this data was presented at the Quad AI. So patients received either daily placebo or Upadacitinib either at the 7.5, 15, or 30 milligram dose. The mean percentage improvements from baseline to week 16 in the EASI and in the itch score were significantly greater with Upadacitinib at all doses versus placebo. In addition, at week 16, the absolute eosinophil count was significantly lower with the 30 milligram Upadacitinib dose versus placebo, with significant differences seen as early as week 2. However, there was no change in the IgE levels regardless of the dosing of upadacitinib up to week 16. Let's switch gears and talk about another mechanism of action, specifically PDE inhibitors or phosphodiesterase inhibitors, one of them being a molecule called difamilast. PDE inhibitors exert anti-inflammatory action by increasing the intracellular cyclic AMP concentration, which inhibits the production of inflammatory cytokines and other mediators. Difamilast is a PDE4 inhibitor, which is highly selective for PDE4B and is being developed as a 1% ointment for the topical treatment of mild to moderate atopic dermatitis. Results of a phase 2 study in pediatric patients with atopic dermatitis giving difamilast 1% ointment twice daily for up to 4 weeks showed that difamilast demonstrated rapid itch relief with the median time to itching improvement by 5.76 hours. In addition, the itch score decreased up to a maximum of 63.6%, and the numerical rating scale decreased from a baseline of 7 up to a maximum of 65.7% at 12 hours. In addition, based on the IgA, percentage of patients with moderate to severe atopic dermatitis decreased from 90.6% at baseline to 39.3% at day 29. And in this study, no serious adverse events were reported. The last study we will talk about focuses on a novel non-steroidal cream called Tapinarof. Tapinarof cream is a aryl hydrocarbon receptor modulating agent which is under investigation for treating atopic dermatitis and psoriasis. Results from a phase 2b study evaluating secondary outcomes in patients with atopic dermatitis showed greater reduction in mean percentage body surface area affected from baseline in Tapinarof groups compared with vehicle groups from week 1 and onwards, which was maintained up to week 16. There was also greater reductions in the mean total severity score from baseline in Tapinarof groups than vehicle groups from week 2 and onwards. The most common adverse events seen in the Tapinarof group were nasopharyngitis, folliculitis, and a worsening of the atopic dermatitis. In conclusion, data presented at the AAD and Quad AI confirmed the economic burden associated with a longer time to treatment escalation for patients with atopic dermatitis, as well as the efficacy of Dupilumab, including among adolescent patients, and its use in the pediatric population was also explored and appears promising. Other novel agents being investigated, including JAK and PD inhibitors, also seem promising and may have the potential to further personalize the management of this condition. That ends our discussion for atopic dermatitis. Now please stay tuned for Dr. Koren's presentation on asthma, chronic rhinosinusitis and nasal polyps, and eosinophilic esophagitis, which will begin shortly. Thank you very much for your attention.
Hi, my name is Jonathan Koren, and I am a member of the clinical faculty in the departments of medicine and pediatrics at the David Geffen School of Medicine in Los Angeles. Today I'm going to be talking about data about treatments for asthma, chronic rhinosinusitis, nasal polyposis, and eosinophilic esophagitis that were presented recently at the National American Academy of Allergy and Immunology. As an introduction, a significant proportion of patients with asthma are not very well controlled with inhaled corticosteroids and long-acting beta agonists, as well as other medications. Many of these patients are dependent either on taking oral corticosteroids frequently on a recurrent basis or chronically over long periods of time, which can be associated with serious long-term side effects. There are a number of emerging and approved targeted biologic therapies that can provide the opportunity to these patients to achieve asthma control and markedly limit their use of oral corticosteroids. Options for targeted asthma therapies have recently been expanded and will likely continue to grow in light of the numerous therapies that are currently in development. We're going to first start by examining some of the therapies directed at interleukin-5. There is a growing body of data for anti-interleukin-5 therapies, which include both Mepolizumab and Ruxolitinib, as well as Benralizumab, which targets the IL-5 receptor. Mepolizumab, Ruxolitinib, and Benralizumab have all been approved as add-on maintenance therapy for patients with severe asthma who have an eosinophilic phenotype. It's important to keep in mind that Mepolizumab and Benralizumab have been approved down to the age of 12 years, while Ruxolitinib is approved for patients 18 years and older. Some of these therapies are also being studied for their impact on other type 2 comorbidities, including allergic rhinitis, chronic rhinosinusitis, and nasal polyposis. So we're going to start with some discussions about data regarding Mepolizumab in patients who have concomitant asthma and upper airways disease. The first abstract that we're going to look at severe asthma who have a meta-analysis taken from several databases, including the DREAM, MENSA, SIRIUS, and MUSCA studies. The goal of this particular meta-analysis was to compare patients who either had self-reported upper airway disease or not, and compare these two groups with regard to asthma outcomes. When we now look at the actual data reported by these patients, patients had similar improvements in asthma control questionnaires, St. George respiratory questionnaires, and reduction in exacerbations of asthma, suggesting that anti-IL-5 therapies are equally effective in patients whether they have a history of upper airway disease or not. The next abstract is a report of a small group of patients with uncontrolled severe eosinophilic asthma who were followed by a clinical practice in Spain. The baseline period of this study is the 1 year leading up to the initiation of therapy with Mepolizumab, and this 1 year was compared with a period of 4 to 6 months after initiating therapy. All patients were being treated with GINA Step 5 therapy. 8 of the patients had allergic asthma and 10 had previously received Omalizumab. The exacerbation rate dropped from 44 in number during the baseline year down to 4 during the 4 to 6 months following the initiation of Mepolizumab therapy. FEV1 improved significantly, and eosinophil counts demonstrated an 81% reduction in eosinophils during the period of treatment. Our next abstract addresses the issue of stratifying patients who were treated in the MENSA and MUSCA trials with Mepolizumab on the basis of their eosinophil counts. Patients were treated with 100 milligrams subcutaneously during the treatment period, and roughly 470 patients were treated in each treatment arm. What we learned from this study is that as eosinophil counts increase in an incremental way, the improvements seen with Mepolizumab improve similarly, with a 30 to 71% improvement, which can be seen very nicely on this graphic. We're now going to talk about another anti-IL-5 antibody, Ruxolitinib. This first study that's going to be assessed was an analysis looking at baseline characteristics and then looking at asthma outcomes over a 52-week period of treatment. Patients all had screen eosinophils of greater than or equal to 400 cells per microliter, and the treatment during the study was Ruxolitinib 3 milligrams per kilogram of body weight given every 4 weeks intravenously versus placebo. The purpose of this study was to examine how many patients responded appropriately to the anti-IL-5 antibody with an expected suppression of eosinophil counts. Patients who did not exhibit this response were considered non-responders, partial responders, or late responders. Of the 477 patients, 17 patients without missed doses did not achieve the eosinophilic response that was expected. 13 of these were either non-responders or partial responders, and 4 were late responders, defined as a reduction in eosinophil counts following the initial 4 weeks. Now, interestingly, when we look at some of the baseline characteristics comparing the non-responder partial responder group versus the overall population, we find that there were some differences. Presence of nasal polyps, 7% in the non-responder partial responder versus 26% in the overall group. Median baseline eosinophils, 700 versus 500. Total IgE was markedly different, 1932 versus 600 micrograms per liter. And finally, time since diagnosis, much longer in the partial responder, non-responder group, 27 versus about 15 years. Of note, patients who were in the non-responder partial responder group did not improve statistically significantly clinically. So what I think we can draw from this is that in a small percentage of patients receiving anti-IL-5 antibodies, there may not be the expected reduction in eosinophils, and that will have a powerful impact upon treatment. Our next abstract also deals with Ruxolitinib, and in this case, the investigators sought to answer an important question. How many patients reach a complete exacerbation response, meaning 0 exacerbations throughout the period of study? Patients receiving Ruxolitinib in this 52-week trial, 68% of the time had a complete reduction in exacerbations down to 0, compared with 50% of patients receiving placebo. Interestingly, in patients who had a response either by ACQ or FEV1 during the first month of therapy, were much more likely to achieve a complete reduction in exacerbations, with 77% of actively treated patients versus 45% receiving placebo reaching this goal. We're now going to change gears and talk a little bit about Benralizumab. Very interesting abstract was presented, trying to define, are there real differences between men and women who were treated in the clinical trials, Scirocco and Kalima? This group of patients were defined as having greater than 300 eosinophils per microliter of blood, and a number of baseline characteristics were examined. The only thing that really stood out as a differentiator between the male and female patients was the presence of upper airway disease, which was more common, whether it be concomitant rhinitis or nasal polyps in the men that had entered the study. The next abstract moves away from anti-IL-5 and anti-IL-5 receptor drugs and focuses on a drug that we've had access to for a much longer period of time, Mepolizumab. Mepolizumab, which is an anti-IgE antibody, in this particular case, was examined for its ability to reduce eosinophil counts in the blood during a period of study. The results from the study showed that patients who started off with much lower eosinophil counts had a much lesser effect of Mepolizumab on reducing those counts. If we actually look at the data both for children as well as adults and adolescents with severe allergic asthma, what we find is that the patients who had eosinophil counts of greater than 400 were much more likely to demonstrate a significant reduction in eosinophils. I think what we can conclude from this is that the mast cell stabilizing effects of Mepolizumab do have an effect on the release of type 2 cytokines like interleukin-5, which subsequently draw eosinophils into the airway. The newest biologic therapy to be approved for patients with uncontrolled asthma is Dupilumab. Dupilumab, which was originally approved for patients with poorly controlled atopic dermatitis, is an inhibitor of the IL-4, IL-13 receptor. Both of these cytokines play key roles in type 2 inflammation, and particularly in drawing eosinophils into the airway, in increasing the basement membrane thickness, and causing airway hyperresponsiveness. Dupilumab was approved for patients as an add-on therapy with moderate to severe uncontrolled asthma, 12 years of age and older, with an eosinophilic phenotype, as well as patients who are oral corticosteroid dependent. There were a large number of studies presented at the Quadruple AI meeting dealing with Dupilumab and its effect on various subsets of patients with asthma. These included patients with allergic rhinitis, chronic rhinosinusitis, and nasal polyposis. Along with its recent approval for uncontrolled asthma, the FDA has also accepted Dupilumab as a priority review for its effect in chronic rhinosinusitis with nasal polyposis. Currently, there are no approved biologic therapies for patients who have severe chronic rhinosinusitis and nasal polyposis. We know that there are several common comorbidities that go along with asthma, including allergic rhinitis, rhinosinusitis, and nasal polyposis, and all three of these diseases add up to increase the overall burden of disease for patients with airways disease. We're first going to talk about the effect of Dupilumab in patients with chronic rhinosinusitis with nasal polyposis. There were two late-breaking abstracts presented at the Quadruple AI meeting. One, a 24-week study of Dupilumab in, we'll call it CRS-NP, the other a 52-week trial. Both looked at both efficacy and safety of the 300 milligram dose of Dupilumab given every 2 weeks in patients who were on a background of mometasone furoate nasal spray. Of these patients who had CRS-NP, 75% of patients had a history of some other comorbid type 2 disease, and 58% of these people had comorbid asthma. Let's first take a look at the 24-week data presented at the Quadruple AI meeting. In this study, over a period of 6 months, there was a 42% improvement in sinus opacification versus 4% with placebo, seen on the CT scan. There was a 146% improvement in patients' ability to smell. which is one of the problems that patients identify as being worst in those who have CRSNP. There was a 60% improvement in health-related quality of life versus only 18% on placebo, and there was a significant reduction in the proportion of patients who required systemic steroids and sinonasal surgery by 73%. Now, what's important to know is that many of these improvements, as you can see from the graphic, occurred as early as 4 weeks into the study. We'll finish with the idea that in patients who had concomitant asthma with their CRSNP, that many of these patients had improvements in asthma and improvements in pulmonary function. As we've seen in both asthma and atopic dermatitis, Dupilumab was safe and well tolerated. The next graphic displays how Dupilumab worked during the 24 weeks of study, showing the reduction in symptoms and nasal polyp score at 4 weeks, which continues to improve throughout the entire study duration. The 52-week study in patients with CRSNP was conducted in order to determine whether a longer period of study showed additional benefits and to have a longer period of safety observation. Again, the vast majority of these patients had some type 2 comorbid disease, and nearly 60% had concomitant asthma. Very similar to what was seen with the 24-week study, there were improvements both in sinus opacification as measured by CT scan, very large increases in the ability to smell, improvements in health-related quality of life, and very importantly, reductions in the need for steroids and sinus surgery over the 52-week period. Similar to the first study that we looked at, there were improvements in asthma symptoms as well as lung function over the 52 weeks, and again, Dupilumab was found to be safe and well tolerated. What I find interesting about the graphic that you're now looking at is that after the initial 24 weeks, there continued to be improvement, both with regard to the nasal polyp score as well as the nasal congestion score. So one could speculate that the longer this drug is taken, the better improvements seen over long periods of time. The next two abstracts are going to concentrate specifically on the ability of Dupilumab to reduce type 2 inflammatory biomarkers in patients who had concomitant upper airway disease. The first of these specifically looked at patients with concomitant allergic rhinitis and found that when you compared patients with allergic rhinitis versus the general population in the study, there were no significant differences in the observed reductions in exhaled nitric oxide, total serum IgE, and serum eotaxin 3. The second study looked at patients who had chronic rhinosinusitis with or without nasal polyposis, and again demonstrated very similar findings, that whether or not patients had concomitant CRSNP, the suppression of the inflammatory biomarkers, nitric oxide, IgE, and eotaxin 3 were similarly suppressed compared with the general population of the study. Our next abstract addresses the question, do patients who have concomitant allergic rhinitis along with their asthma respond just as well to patients who do not have self-identified chronic upper airway disease? One of the impetuses for doing this is that we often consider patients with allergic rhinitis to have a more severe form of global airway disease, since it involves both the upper and lower airway. The data from this particular abstract demonstrates to us that irrespective of whether patients have a history of allergic rhinitis or not, the effects of Dupilumab are approximately the same, with improvements in exacerbations and lung function. Understanding that Dupilumab can affect both the upper and lower airway, the next abstract attempts to answer the question whether Dupilumab has a significant effect on the rhinoconjunctivitis-specific health-related quality of life. What we can see from the graphic was approximately 12 weeks after initiating therapy with Dupilumab, there were significant improvements in rhinoconjunctivitis-specific quality of life that persisted throughout the remainder of the study. Up until now, we've been looking at the effect of Dupilumab in patients who had been primarily diagnosed with asthma and trying to examine the effects on other comorbid conditions like allergic rhinitis or chronic rhinosinusitis. In the next abstract, we're going to spin this a little bit differently and look at people who had been entered into the atopic dermatitis trials and now looking to see in people who had severe atopic dermatitis, how did Dupilumab affect other conditions such as allergic rhinitis or chronic rhinosinusitis. In order to measure the effects on asthma, the ACQ-5 instrument was employed, while for patients with chronic rhinosinusitis, 22-item sinonasal outcome test, so-called SNOT-22, was utilized. At the same time, patients underwent standard measures of atopic dermatitis, such as the Eczema Area and Severity Index. What we can see from this graphic is in patients who had primarily been diagnosed as atopic dermatitis and entered into clinical trials for their skin disease, that at the same time there were significant improvements in both asthma as well as allergic rhinitis and chronic rhinosinusitis. Let's now turn our attention to another part of the body, the esophagus. And over the past several years, we've been gaining an appreciation that eosinophilic esophagitis can be a very disabling disease, which is typically seen in people with other type 2 comorbidities, such as allergic rhinitis, asthma, and chronic rhinosinusitis. Our next abstract is a retrospective analysis of 71 patients with eosinophilic esophagitis. And what we learned from this analysis is that the vast majority do have comorbid type 2 conditions, led by allergic rhinitis with 69%, food allergy in 55%, allergic asthma in 41%, and atopic dermatitis in 17%. Based on the discussion that we've had up until this point, we can make a conclusion that many of the type 2 conditions do share a considerable amount of pathophysiology, particularly the roles of interleukins 4 and 13 in causing many of the symptoms of these diseases. For this reason, a number of pharmaceutical companies are investigating the utility of using IL-13 inhibition or IL-4/13 inhibition by blocking the receptor in patients with eosinophilic esophagitis. From the Quadruple AI meeting, there were a couple of abstracts, I think, that garnered our interest regarding the role of this type of therapy in patients with eosinophilic esophagitis. This first abstract deals with the IL-13 inhibitor RPC4046, and what we're going to be looking at is the open label extension that lasted for 52 weeks following the double-blinded portion of the efficacy trial. And what we learned from this particular abstract is that mean esophageal eosinophil counts remain stable in patients who had previously received the active compound, and for patients who had been randomized to placebo and were now switched to the RPC drug during the open label extension, there was a marked reduction in eosinophil counts taken by biopsy. While tissue eosinophil counts are obviously very important, I think most would agree that symptoms are probably an even more important endpoint. And with regard to this particular abstract, at baseline, 24% of the patients had achieved symptomatic remission, considering that many of these people had already been in the double-blinded portion receiving the RPC drug. But we see that going from week 12 to 24 to 52, a peak of 58% of patients were in symptomatic remission during the trial of this drug. Now, the last abstract, again, is focused on the RPC4046 interleukin 13 inhibitor. In this particular study, this was a post-hoc analysis of a subset of patients who had steroid refractory disease and were randomized to either the 360 or 180 milligram dose. The primary endpoint was a change from baseline in mean esophageal eosinophil counts at week 16. In comparison with placebo, even in this subgroup of patients who had very refractory disease, there were significant reductions in eosinophils. And if we now look only at the 360 milligram group, the symptom severity score was also significantly improved compared with placebo. I think we can all agree that there was a great deal of very interesting and provocative information presented at the Quadruple AI meeting with regard to the role of new biologic therapies for patients with uncontrolled asthma, chronic rhinosinusitis with nasal polyposis, and finally eosinophilic esophagitis. While we currently have a number of approved therapies for patients with uncontrolled asthma and atopic dermatitis, we are just starting to see new information produced on some of these other type 2 conditions. And I want to leave you with one thought. Because type 2 diseases tend to cluster in individual patients with multiple disease manifestations in individuals, these therapies may prove to treat more than one disease at a time. I'd like to thank you all for listening in and learning what I learned from the Quadruple AI meeting, and hope you found it interesting.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/NCE860. This educational activity is supported by an educational grant from Sanofi Genzyme and Regeneron Pharmaceuticals. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer Review Institute for Medical Education.